Respiratory system, palpation. Introduction. The patient's history determines the scope and intensity of the chest examination. When the history elicits suspicion of the presence of a chest problem, the physical examination of the thorax must be expanded beyond a minimal screening examination to determine the nature of the problem so that a diagnosis can be made. Technique. The pulmonary examination consists of inspection, palpation, percussion, and auscultation. Palpation is used both as a screening technique and as a means to confirm a specific diagnosis. What to observe while palpating: any swelling, any pain or tenderness, position of trachea, chest expansion, chest symmetry, tactile vocal fremitus. Procedure. Introduce yourself and confirm the patient's identity. Explain what is going to take place and ask for consent. Ask the patient to sit in an upright position. Note the temperature, moistness, and turgor. Examine for any edema. Rule out any pulsations, bulging, masses, depressions, or unusual movement. Check the tracheal position by palpating between the heads of the two clavicle. A slight deviation of trachea to the right is normal in healthy people. Trachea is displaced to the affected side in conditions such as fibrosis or collapse. Palpate over the sternum. Look for any structural deformities such as pigeon chest or funnel chest. Feel for chest expansion. Grip method. Face the patient before proceeding. Place both hands firmly on the anterior chest wall on the lower rib cage with the thumbs meeting in the midline of the patient's chest. The thumbs must not touch the chest. Ask the patient to take a deep breath in and note the distance as both the thumbs move apart during inspiration. Then ask the patient to breathe out and note the distance during expiration. The movement must be equal on both sides. Repeat these steps on the back of the patient. The affected side is prominent and chest expansion is reduced in pneumothorax, pleural effusion, and emphysema. The affected side is shrunken with reduced expansion in fibrosis and collapse. To find out the chest symmetry, you must measure the chest expansion and hemithorax using a measuring tape. Take the tape and encircle the patient's chest around the level of nipple. Take measurements at the end of deep inspiration and expiration. Normal chest expansion in a healthy young man is 5 to 8 centimeters. Chest expansion in emphysema patients may be less than 1 centimeter. Measure the right hemithorax by encircling the tape from the vertebral spine to the midpoint of the sternum. Ask the patient to take a deep breath and then exhale. Measure the right and left hemithorax during inspiration and expiration. Asymmetrical chest expansion can be seen in pneumothorax, pleural effusion, fibrosis, or extensive consolidation or collapse. Palpate for right supraclavicular lymph nodes by asking the patient to move the head slightly to the right so that the skin relaxes. Palpate deeply just above the clavicle to assess the supraclavicular lymph nodes. Do the same on the left side. Palpable nodes could suggest the presence of infection or metastatic disease. Check for tactile vocal fremitus by placing the ulnar edge of your hand on the chest. Now ask the patient to say 99. Check the fremitus in the upper, middle, and lower areas of both lungs on the front and back side. Vocal fremitus is decreased in pleural effusion, pneumothorax, and emphysema. It is increased in consolidation and neoplasm. Physical findings must be interpreted in light of all previously collected data. The general scheme is to develop a postulate and test it with further history, additional observations or maneuvers on physical examination and laboratory tests.